Hello, everyone, and welcome to the IOCDF's Research Roundtable, the IOCDF's live stream where we pick an interesting and hot topic in the OCD literature and discuss it with the people who know it best. My name is Kyle King. I'm a senior here at Yale University studying neuroscience, and I'm one of the co-hosts of today's program. I'm also joined by my co-host, John Abramowitz. John, if you'd like to say a little word about yourself.
Sure. I'm John Abramowitz. I'm a professor at the University of North Carolina. I study OCD and I always enjoy our monthly meeting here with Kyle and awesome guests like we have today.
Yeah, we do have a really interesting lineup today and a really interesting program today. I want to apologize at the beginning. My voice is a little bit more hoarse than normal. I'm a little bit under the weather, so bear with me. And also, bear with me, because before I introduce our guest today, I do have to go over some general announcements. So I'll do that now. First, this live stream is educational and is not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find-help to locate a trained clinician near you. Also, the IOCDF is not a crisis hotline. If you're in a crisis or if you're ever feeling suicidal or unsafe, please call the 988 Suicide and Crisis Lifeline by dialing 988. You can also access online at www.988lifeline.org. Go to your local emergency room or call 911. Also, there is a chat function here. We love when you guys type stuff in the chat. Please put where you're from, what you had for breakfast this morning, what you ate for dinner last night, whatever you want. And also feel free to ask questions because we'll try to answer them the best we can on the live. Just know that whatever you put in that chat will be there forever. It is live, so just be conscious, although everyone always is. All right, cool. I think that's all the announcements that I have to make. Might as well start introducing the much more interesting people that we have on the live stream today. I'll start in the order of names that I have on my screen with David Matesh Coles. Did I get it?
Very good.
All right. David is a professor of child and adolescent psychiatric science at the Karolinska Institute and leader of the Obsessive Compulsive and Related Disorders Across the Lifespan Research Group. David, I guess I kind of asked this to the people in the chat. What did you have for dinner last night?
I think, that was unexpected. I think it's some sort of breaded chicken or something.
All right. You seem to have a really sharp memory. I like it. Our other guest, or our second guest, is Lorena Fernandez de la Cruz. Lorena is an associate professor in the Department of Clinical Neuroscience at Karolinska Institute. She's the leader of the Health Consequences and Lifestyle Modification team in the Obsessive Compulsive and Related Disorders Across the Lifespan group at Karolinska. And since September 2018, she has been the equal treatment representative at CNS. I'll ask you the same question, Lorena. What did you have for dinner last night?
Now I was prepared, so I'm lucky.
Yeah, David got a little bit of a harsh treatment.
You should have told us before. I had some bread and cheese because this weekend I was at the cheese festival and I bought some cheese. So
what?
Yeah.
What is the cheese festival?
Yeah,
Sounds phenomenal.
I know. It was.
All right, I'll have to go to Sweden just for the cheese. And our other guest is Sanjay Saxena. Sanjay is the IOCDF's Director of Clinical and Research Affairs. He's an expert in neurobiology and the treatment of OCD and hoarding disorder. And he was previously the director of the UCLA OCD Research Program. And he's, I believe, currently the director of the UC San Diego OCD Research Program. I might have messed up that bio. Sanjay, how are you?
Doing well. Thanks for having me on the program.
All right. Should I hit you with the tough question?
Sure.
What did you have for dinner last night?
Yes, I was prepared too. Yeah.
Okay.
Fish and vegetables.
Okay.
Nice.
Much quicker answers. I like seeing the first person's face when I ask them the weird intro question, and then everyone else get a little bit calmer. So today we are going to be discussing a number of different things, but at least in the offset, we're going to be focusing on a paper of which David and Lorena are both authors on. So they're good people to have on the program. The paper's titled "All Cause and Cause-Specific Mortality in Obsessive Compulsive Disorder Nationwide Matched Cohort and Sibling Cohort Study." That's a very long title. And I was, so just kind of by way of stage setting a little bit, sent this paper by a number of different people, most of which were advocates. And as someone with OCD, when I read this title about mortality in folks with OCD, I was a little bit alarmed. And so were the other advocates who sent me the paper. And I tried to do I tried to calm myself down and remind myself that, scientific papers tend to contain a lot more than just the title. And it'd probably be a smart thing before freaking out about the title, just to try to understand what this study is really saying and what really are the implications of this study. So that's what we're going to try to do on this live stream today, at least in the beginning. Look at the study, try to break it down, and think systematically through the implications of it. And then talk about kind of the broader context in which the study is situated, both within OCD and in other psychiatric disorders at large. That's probably, though, all that you want to hear out of me. So I'm going to turn it over to the authors of the study, just with a very simple question at first. What kind of was the research question for this study when you went in to conduct it?
Shall I start?
Yeah, go for it.
Yeah, so for the past few years, we have been researching the associations between health in general and OCD, and we thought that it was also good to look at mortality, and we understand that this is alarming, but I want to say two things. First is that this is something that we know already, that mental disorders are associated with an increased risk of mortality. And I guess the message here is that OCD in this sense is now different from other mental disorders. And now we need to discuss how we can use this information so that is actually a good thing for us to know. And then the other thing is that this study includes 60,000 people with OCD and that we are presenting results at the group level. So now we can start seeing how we can use this information and how each individual can extract something that they can use for their daily lives. I don't know if I answered your question. But we were, yeah.
I think you answered it well enough. So the idea was just to kind of get a sense of, I guess, different rates of mortality in folks with OCD, depending, or stratified by condition. Is that about right?
So what we have, so I think that I want to also kind of set the scene. So David and I, we are not from Sweden, but we live in Sweden. And one of the main reasons is because Sweden has these very large population registers where we have data from health data and administrative data from the whole population. And the fact that we have, Sweden is not a very large country, but the fact that we have data from all the population allows us to answer questions where we need a long time to have passed or where we need larger samples. So it's not that easy to study mortality because you have people that are diagnosed with something, for example, OCD, and then time needs to pass. And we need to follow up those people in a way, wait until they develop a disease or wait until they die. So we have been able to do this only in this context. And in this way, we have been able to gather information from these very many people with OCD and compare them with people from the population that are demographically similar, so they have the same gender, the same age, but that they don't have OCD. And then we have looked at the ones that have died, and we have studied what are the causes of death. And then, as you said, then we have different groups. So we have what we call external causes of death or unnatural causes of death. And then we have suicide and accidents. And the most novel thing here, I believe, is that we have also been able to study natural causes of death. And then you have, circulatory diseases, endocrine diseases, pulmonary diseases, which is something that we have now information about these causes that we did not have before.
And you said earlier that, kind of going into the study, we know that psychiatric conditions in general are associated with increased mortality rate. Is that right?
Yeah.
So I guess what did you guys find in this study? Is that maybe too broad of a question?
Yeah, no, but I think we can take it from there. So we found things that, as I was saying, we already know, but that are still very helpful when it comes to prevention and when it comes to seeking help which is that OCD is associated with an increased risk of suicide. And this is, I believe, something very, very important, and that long time ago, people thought that maybe people with OCD did not have an increased risk of suicide, but now we know that it is actually the case. And this is good for people with OCD to know, for their carers to know, their family, health providers to know, so that we keep an eye on ourselves, and people that are treating people with OCD also keep an eye on it, and that we develop services and preventive resources that focus on this. And so that's one of the main findings, that the risk of suicide is higher in OCD. And we also found that the risk of some natural causes of death is higher. We have been studying, for example, metabolic and cardiovascular diseases for a while. And we have established now that people that have OCD also have an increased risk of these circulatory diseases, obesity, type 2 diabetes, and now we have also seen that this is associated to an increased mortality due to these causes. So this is something that needs to kind of promote that we find some help for this when it comes to health services and so on.
David and Sandra, I don't know if you have anything you want to add.
I'd like to add something that on the topic of alarm. So that's one of the first things you said, Kyle. So should people be alarmed? And I think it's important to put the results in the context of so understanding the difference between an absolute risk and a relative risk. So the numbers that people will remember from the paper are probably the relative risks. So for example, people with OCD are twice as likely to die in this 20-year follow-up period. But the actual proportion of people with OCD who died, so the absolute risks, are actually quite small. So if you, I don't know what table it was, table 2 of the paper. So it's not that people will just drop dead in large numbers. This is not a pandemic situation. So they're very small numbers. However, they're still higher than what we would like them to be. So. And those are the relative risks. So it's a bit of a wake-up call. Even though people should not panic, it is still a wake-up call in the sense that we probably need to take the somatic health of people with OCD much more seriously than what we have done so far.
And if I can make a comment, I want to just add to that to help people understand, because you're right, there were some folks who initially saw the headlines and were alarmed and then were writing to us or asking questions. What the findings are not that people are dying of OCD, right? It's that having OCD, just as with having other mood disorders, other anxiety disorders, even to a greater extent substance abuse disorders, and some other psychiatric disorders, have an elevated risk of death from a whole variety of different conditions. And some of that is driven by the comorbid other psychiatric disorders. So I think David and Lorena can talk a little bit about when they adjust their findings, let's say for comorbid depression, which clearly has always been well known to have a markedly elevated rate of suicide. The risk found in OCD when you adjust for that is lower than it would be if you didn't adjust, but it's still elevated, right? So all of these disorders convey elevated risks of suicide because of their impact on our global sense of well-being and mental health. But they also convey risk of all those other medical disorders that they're going to talk about, and that's for a whole variety of reasons.
Exactly.
Yeah.
So we're also very careful in the paper to never use causal language. So we speak of association between OCD and a certain cause of death, because it is a descriptive study. We do not know exactly why people are more likely to die. And it's likely to be a variety of reasons, which I'm sure we will discuss tonight.
I'm planning on getting there.
It's not night for you, but it is for us.
And the other comment that was coming up amongst some of the folks, people with lived experience of OCD or advocates that were coming in were sort of expressing alarm, thinking that this was a novel finding, something that was brand new and startling to them. And one message that we wanted to send is that the findings of the study that David and Lorena and their colleagues have done fits extremely well with quite a bit of previous literature. So it's not really new. It's more well described. They've done a great job at really dissecting a little bit more in terms of all the different potential groups of medical disorders that convey risk, and it's a more sophisticated analysis. But the overall message and findings are quite similar to previous work that's come out over the last 10 years or so.
Yeah, there is actually also from the Nordic countries, but there's a Danish study that also looks into OCD and mortality, that because the sample is not as large, they were not able to look at the specific causes, but the overall risk of mortality is actually the same that we found in Sweden. And it was like really reassuring to see that the results were consistent in two different countries, even if in many ways they are similar. So yeah, in that sense, the results are not novel. And as you say, it also matches the literature in other disorders.
There's a couple different interesting lines of questions that I want to take up. And there's also some questions in the chat, which I'll try to pepper in. The first kind of question I had, Sanjay, you talked about like adjusting for different comorbidities. And, I'm not big into statistics. So, like, what does it mean to adjust for different comorbidities? And could you all talk a little bit more about, I guess, how comorbidity affects mortality rate?
Yeah, so when you run this kind of complex analysis, you really want to try to establish that the association is, so in this case, that the increased mortality is due to OCD and not to anything else. So you try to also take into account other factors that that are also associated with mortality. So as Sanjay was saying, we know that other mental disorders are associated with mortality. So we try to take that into account in the analysis. So I won't get in the specifics of the analysis, but yeah, you kind of try to see, like how this would look in a person with OCD only and in a person with OCD plus depression. And then the analysis kind of gives you a number that takes that into account. I don't know if that's clear for you.
Yeah, I think I got it. I don't know if Sanjay, David have anything to add.
Yeah, I think
another way to look at those adjustments is that, so generally adjusting for comorbidities reduces the risk. Another way to look at it is that if you have comorbidities, your risk will be higher. But again, we knew this, so it's not a surprise. So the more complexity, the more comorbidity, the worse general health, and eventually the higher the risk of that. So not surprising.
Yeah, and I think another message to let people know who may be watching is that the risk, the increase in risk of mortality is higher for things like substance abuse, for example, and for depressive disorders,
psychotic,
yeah. So then it is for OCD.
Eating disorders, for sure.
Eating disorders, right. So many other psychiatric disorders have even more increase or a greater increase in relative risk of death than OCD does. But the important finding here is that even when you adjust for those, there's still some elevation in risk, and particularly of some very specific causes like suicide in people with OCD.
And I guess we're talking a lot about like increases, but like what does that mean? Like numerically, how big is an increase?
Yeah, I mean, it depends on the specific cause that you want to look at. I believe that in the paper, the highest one was for suicide that I already mentioned, where the risk was about 5 times higher than it is in the control group. But as David was saying, 5% of what? So we have to take into account what's absolute and what is relative. I'm going to look at it because I think it may be interesting for people to see this. I think that the percentages are really quite low. Now I won't be able to find the table. Yeah, there you go. So for suicides in OCD, there was like 1.2% of people during this 40-year period that died of suicide. So this is obviously very important, but it's not as large as we may think when we hear this like 5% increased risk. And for the general population was only 0.2%. So yeah, it is actually 5 times higher in people with OCD. But yeah, as David was saying, people are not like dropping dead because of these causes. And then there are different percentages for the other group of diseases, and they most of them have in common that they are non-communicable diseases. So I think that this is important, like all the cardiovascular, diabetes, chronic respiratory diseases, all these causes that we can classify as preventable. And that's why I think that we need to find not the positive in these results, but that they kind of force us to take action, that most of the causes that we found that are significant can be prevented.
Yeah, like the next steps coming out of this paper are definitely something interesting to think about, and it's something that I want to talk about with you guys later down the line. And also the difference that David brought up of like absolute mortality and relative mortality is something that I take a lot of comfort in personally, knowing that, like, you know, it's not like everyone's dropping dead. It's just a percentage increase, which is significant statistically speaking. But, you know, maybe not something to have an immediate panic over.
No, definitely not. So these are rare events. So we needed 24 years of worth of data and 65,000 people with OCD to be able to detect this effect, which is very, very small.
And I suppose the group effect thing that Lorena, you mentioned very early on is to say that, like, you know, these are averages across 65,000 people, like you said. Like for any given individual, you're not talking about given people, like it's single individuals in these studies. Is that
no, this is at the group. This is at the group level. So yeah, this is data put together from the whole population. So yeah.
So there are a couple questions in the chat. I'm going to start with one that HGS at 1207, and then I'll get to some other ones in a second. First, he asked a while ago, I'm interested to know which respiratory disorders have increased incidence among those with OCD, inflammatory disorders, or were these deaths secondary to infectious respiratory diseases?
Yeah, that's a good question, and I don't have the answer because we did not have that many people dying, so we only have this grouping. So we have only respiratory diseases, but I don't have what specific diseases within the group. If you know what I mean.
Yeah, that kind of goes back to David's point.
The most common are, I mean, I don't know, like a chronic obstructive pulmonary disease, pneumonia. Those are the most common within this group. But we don't know with this study what are the very specific causes. I mean, that's like a planned study to look more specifically at respiratory diseases in OCD to try to understand why there is an elevated risk and what kind. But yeah, with this study, we only have the general group.
Mm-hmm. Okay. And Space Cowboy at 1220 asked what I think is a very fair question. So was the idea of this live stream to be a huge exposure for people with OCD?
Very good question.
No, the point of this study and of this roundtable is to highlight something which is quite important and that we have possibly been neglecting for way too long, which is to look at individuals as a whole. So those of us working in mental health, we have rightly so been focusing on symptom reduction, how to get CBT to people, how to get them the right meds. And obviously that is very, very important, and it remains a top priority for us. But we have for too long been neglecting the other side, which is the somatic health of people. And what we're hoping to achieve with this is that better integrated care for people with OCD that takes into account all aspects, all medical aspects of the person. So I think it's, as I said earlier, a bit of a wake-up call, but I think it's we should think about it in a positive way, in that we know we have a lot of work to do to think more holistically about our patients.
Mm-hmm.
And I think, I think there's a number of additional take-home messages that I think are really important. The study, and especially how it fits with all the previous information that's very consistent with it, is a reminder of how serious the condition is, and highlights the importance of people getting screened for OCD, and for people with OCD to go get treatment, right, and take care of their mental health and take care of their physical health. And there's a number of different places along that pathway that submit. So a lot of folks with OCD, sometimes the majority of people who have found they have OCD in big population studies had never sought treatment. Never talked to anyone, never gotten a diagnosis, never been treated for protection, only somebody came to their home and did.
Sanjay, something's wrong with your audio.
Oh, okay.
Can you hear me? Now you're better. All right, yeah. You might want to go back like 20 seconds though.
Oh, okay, sure. Sorry, something must have been covering my mic. I was saying that the overall take-home message is to highlight the importance of screening for OCD and treating OCD. And this is important for all the folks with OCD who haven't sought treatment, or families or people with OCD who think, oh, it's not that serious, I don't really need to go get treatment for it. It's a reminder that it is serious, and it may have serious consequences for your ability to get good health care, for maybe a direct effect on other aspects of your mental health that include suicidal ideation, as well as a variety of other medical conditions that are associated. Mm-hmm. It's a reminder to clinicians to screen for OCD and treat it, because it's yet another psychiatric disorder that has significant impact on people's overall physical health, as well as their long-term risk of mortality.
Yeah.
Mm-hmm. Yeah, I think the idea of thinking about it kind of like as this reminder, I like that word, of like, hey, this is a serious thing that we should really focus on. OCD is kind of a helpful way to frame it. And one thing that I kind of like that Lorena referenced, or alluded to rather, is that, this is kind of a study that we should acknowledge these results because they are the case, and we should think forward after these results. Like, what does this mean for policy or advocacy, or what clinicians should be thinking when they're thinking about OCD? So what do you guys think are like the next steps from a paper like this?
we have been actually working already on the next steps, and this is something that I wanted to bring up, which is a focus on the lifestyle of people with OCD. So we know now from the studies that we've done that people with OCD tend to have lower levels of physical activity, that tend to eat not as good as they could. They also have sleep problems, and this obviously adds up to these risks that we are mentioning, right? Because if you're physically inactive and you have a sedentary life, you also have an increased risk of obesity, so that increases your chances. So we are now working on lifestyle interventions, so that people with OCD we help them changing their habits, because we know that this is very difficult for any of us, really, but if you have a mental disorder, it may be even more complicated to introduce changes on your daily life. So we believe that helping people to change their habits may reduce this risk of diseases and mortality in the long term. And I think that's why I was trying to frame this in a positive way, that this is a good thing to know, because we have to take action, take better care of ourselves. And that's not to put the responsibility on people like this is your fault, but to understand that it is good if we take some measures, like keep active and eat better, and try to reduce this risk that we know that exists.
And
Yeah.
I think,
Oh, yes, you go, Sanjay.
No, I was saying, so that's one major contributor is lifestyle things that contribute, especially to elevated cardiometabolic risk, right? And that's one of the big categories that's increased. So taking care of smoking, sedentary lifestyle, diet, and so forth. And so those are things that are more under the control of people with the disorder. Then there's a whole bunch of other factors that are different from that, which really have to do with getting access to care, both for your physical disorders as well as for your OCD, depression, and other psychiatric disorders, and whether you are treated properly for those. So there have been prior studies across other psychiatric disorders showing that people with various psychiatric disorders are less likely to access care, and they're less likely to receive proper care, including for their respiratory diseases, cardiac diseases, and so on, because of how they are treated in the medical system.
Mm-hmm.
And I wonder if David and Lorena can kind of speak to those issues a bit.
Yeah, that's something that we have heard here as well, that maybe due to like stigma or other causes, you go to your psychiatrist or you go to your general practitioner, and then you complain about certain symptoms, and because you have a mental disorder, that's attributed to the mental disorder, and then you have more problems to be referred to a cardiologist or to another doctor to treat your other somatic problems. So yeah, this is indeed a problem.
Yeah, I'm also thinking too a lot about kind of, Sanjay, what you were saying at the beginning, like the lifestyle changes at least are something that are really in a person's control, which kind of gives me hope. Like, it's like you said way earlier, like it's not OCD that's driving these deaths. It's people with OCD have, like, these are associated things with OCD. So it is kind of in your control to help combat some of these things. I was wondering, David and Lorena, is kind of like an elephant in the room. Like, what are kind of the speculations? Is it just lifestyle that may be behind these associations?
Yeah, as I said, ours is a descriptive study, so
yeah,
we don't want to speculate too much. But there are known risk factors. Lifestyle is an obvious one. Chronic stress is another one. So if someone has OCD, they experience a lot of stress, and their lives might be hell on an everyday basis. So that messes up with your body systems, your stress systems and your immune system. So if you experience that over many years, that is not going to help your life expectancy. The substance use, alcohol use, which we know some people might use to self-medicate or to cope better with their anxiety. Tobacco, smoking. So it's a range of factors that are, none of them are rocket science. They're all known to be associated with premature mortality.
Mm-hmm.
And there's the socioeconomic dimension as well.
Yeah.
So, if you have a potentially serious condition like OCD, which impairs your ability to study or to finish an education, it means that you will be less likely to enter the work market. You might be unemployed, or it might be hard to get a job or keep a job. All of that will mean that you have less income. And if you have less income, it also means that perhaps you will not be able to afford the healthcare you need. So there's that dimension as well that we shouldn't ignore. So there's very interesting initiatives, for example, to get people with OCD back to work, or into the workforce if you have an early onset OCD, maybe you've never worked. So very interesting programs that help people have employment and as meaningful lives as possible. So a combination of those lifestyle interventions, proper medical surveillance, proper psychiatric treatment, and also these other socioeconomic factors, all of that, we need all of that together to help people be on track.
Mm. And I mean, as people who think about this a lot, do you have any recommendations for someone like me who has OCD? Like, what sort of lifestyle interventions does the research say, could be really helpful? Or is it just getting treatment for OCD? Is it that simple?
Yeah, I don't think you should have any extra plan for your lifestyle than a regular, like a person that doesn't have OCD. I think that we should keep active, eat well, don't smoke, don't do drugs. That's the same that you would tell any person, but because you have OCD and now that you have an increased risk, it's even better for you if you do all these things or don't do all these things. But I don't think that you need an extra. What we know is that it may be more difficult for you to implement these changes. So we've talked to people here that kind of say, oh, I cannot go to the gym because, with my contamination fears, it's difficult to then use the showers, or I don't want to be in the room with these people because, what if I have a panic attack and they are not going to understand why I have these symptoms all of a sudden? So that's true that it may be more complicated for you to make changes to your lifestyle. And that's why I think that we need to also contribute to, help people like you, but I don't think you need anything extra. But obviously do treat your OCD, because I think Sanjay mentioned earlier that if you have OCD, it's also less likely that that you seek help for your for any issues you may have, because maybe you don't want to be in a hospital because of your intrusive thoughts. So I think that that's probably the first thing.
Yeah, it's an interesting thing. It comes out even in the data from this paper, from this study, is that I was interested to see that if you took a look at the sample, there were close to 16 million people, I think they mentioned, available for matching in this giant database of people from I think 1969 forward. Only 64,000 of those, meaning 0.4% or so, were diagnosed with OCD. So right away we know that's a whole lot less than the actual population prevalence. It's probably only capturing maybe a fifth, maybe only an eighth of all the people, let's say in Sweden, who would be expected to actually have OCD through that long time period, right? So we're getting, many decades. It's not really just who was diagnosed in a given year. If we take a look at who has the symptoms or meet criteria for OCD over the course of a 20 or 30 or 40 year period, almost all the studies in different parts of the world show somewhere around 2 to 3%. But only 0.4% were captured here. So that reflects those. So that says, maybe 4 out of 5, maybe 6 out of 7 people with OCD weren't in the database, and that means that they hadn't been admitted to a Swedish hospital since 1969, and they hadn't been in a specialized outpatient consultation. And again, that fits with data from the United States and other places showing that maybe the majority of people with OCD who have the symptoms don't actually go and get diagnosed, and so they're not detected by the healthcare system. And so it's a little bit harder to then generalize from the findings, but it's, knowing the seriousness, if you take a look at people who were diagnosed and seeing that they have elevated rates of a whole variety of disorders, and an especially important elevated risk of suicide, it's all the more reason why folks with OCD should be getting themselves treatment to decrease those risks in the long run.
Yeah, that's a super good point. I mean, in this sample, we have people that have attended specialist services. So it might be that there are other people with OCD that are being seen like in primary care services, but it's still true that the number is too small for what it should be, and we know from other kind of studies. So yeah, that would be the very first thing to go get help for OCD.
Might the kind of discrepancy there, might that mean that the people who are surveyed in this study are more on the severe end of OCD, or is that maybe not the right way to think about it?
That's a super good question. So there, and I don't have a good answer. We believe that maybe that people, because otherwise you would stay in primary care, right? Only people that are severe enough are sent to specialist services. But it might be that you live in a certain city that is more populated and they have more services. And then if you live, like, let's say in Stockholm, which is the capital, that then you end up in a specialist services. But if you live somewhere else, more rural, then there are no specialist services there. And that doesn't mean that there are no severe patients in these rural areas. Or it might be that you are very severe, but that you're so severe that you do not seek help because you are housebound and you have not gone anywhere to find help. So we don't have a good answer to this. It might be that they are more severe, but it may not be the case. We cannot study the ones that we don't have, so it's impossible to tell. We do know from other studies where we have been able to look at what's the severity of people in the registers, that we have a very good distribution of severity. So we do have people that are very severe, but we have also people that have milder symptoms and people that are more or less in between. So not necessarily we are talking about the most severe.
Okay. Yeah. I was thinking that when I was reading the paper, but then I was kind of going back and forth in my head. Like you were saying, well, if you live in a rural area, then like maybe you don't go to specialty treatment. So, it is kind of complicated to analyze. I want to turn to like actually there's a couple questions in the chat that I first want to get to. There's been a number of questions about like the association between OCD and autoimmune disorders. I guess from your guys' perspective, what does that association look like?
Yeah, I mean, correct me if I'm wrong, Lorena, but I don't think that was.
We don't have it as a group because autoimmune diseases are like scattered around these different groups that we were mentioning. So it's difficult to look at it in this paper.
Yeah, and So this is a very interesting topic that we have also been interested in for a number of years. So there seems to be quite a clear association between OCD and also Tourette's, by the way, if we have any viewers with Tourette's, and autoimmune diseases. A wide range of autoimmune diseases, as you probably know, they tend to pile up. You know, they tend to, if you have one autoimmune disease, you tend to have others. And so for some reason, they're more common in people with OCD and Tourette's. And we think that it's partially a genetic link, because they tend to run in families. So it could be that, say, one family member has OCD, and then a close relative does not have OCD but has an autoimmune disease. So we see this quite a lot. The significance of it is a bit unclear. As I said, there could be a genetic link between the two, but the message is kind of the same. So if you have OCD, take care of all of your health, not just the OCD. So OCD will come with all sorts of other things that may be more or less disabling. So some of the autoimmune diseases are not very disabling, whereas others are very disabling. But regardless, just take care of all of you. Just seek help for all of those somatic conditions as well.
Yeah, in the broader literature, again, going back, more than 20 years, it's been found that there are specific categories of illnesses that are overrepresented and at a higher rate in people with OCD as compared to the general population. So autoimmune thyroid diseases and some other endocrine ones, but particularly thyroid disease. Skin diseases, so eczema and other autoimmune skin diseases, migraines, and then autoimmune respiratory diseases and allergies. All of those are found at a significantly higher rate in people with OCD than in the general population. And if you look the other way, there are categories of other illnesses that show a higher rate of OCD. So there's certain neurological disorders that carry with them a high rate of OCD. And if you take a look at folks with various autoimmune conditions, they have a higher rate of OCD. So it looks like it's a two-way relationship that would suggest more likely that it's genetically based or familially based, rather than the product of having OCD that somehow causes these. It's more that people with one are more likely to also have the other.
Mm-hmm.
So what sorts of things did, I guess, David and Lorena, you find, and Sanjay, you know of, that have kind of like this, or OCD is potentially genetically linked to, maybe rather than just being a health lifestyle association?
You mean the association between OCD and autoimmune diseases?
Well, yeah, like that's an example of something that there may be a genetic foundation. What are some other of those sorts of things?
Good question.
So
you ask very difficult questions, Kyle.
Do I? I don't mean to, honestly.
Because causality is very difficult to establish. Very difficult.
Yeah.
Because we don't know what started first, whether this is the genes or if it's OCD causing whatever else comes later, or if it's OCD causing something else that caused something different. Or if it's, as Sanjay was saying, that you have one vulnerability that it happens to be genetic that causes both things. So we just see the individual that has two things at the same time. And it's super difficult to establish, what's the directionality. So the answer is that we know very little about whether this causes these. We just know that there are some things that may be protective, or that may reduce this risk, or that make you better. And I think that when we talk with the patients in an individual basis, those are the things we need to focus on. I mean, we also need to focus on the broader picture and try to find the causes to try to prevent them in the long run. But I think that will take us a long time. I know this is not a good or satisfactory answer, but I think that's probably the closest to reality.
Yeah, the way.
Sorry, go on.
Oh, I was just going to say that, the way you determine whether different disorders or different physical conditions or mental conditions are genetically related to one another is to do either twin-based studies, family studies, or actual genetic and genomic studies. And so there have been, a number of those done within OCD, and even looking at if there's a genetic relationship between OCD and other psychiatric disorders, and there is. So certain of them do run in families, and they do have overlap of risk genes, and they're found in families together. Things like Tourette syndrome, to some extent, eating disorders, some of the what we call OCD-related disorders like hoarding disorder, trichotillomania, body dysmorphic disorder, and so on. There have been a lot fewer such studies that take a look at whether OCD is genetically related to, let's say, cardiac disease or respiratory disease or autoimmune disease. I think there is some literature, but I don't think the studies are anywhere near on the scale of the family and twin and genetic studies that you need with big populations to really establish, is there shared risk? I think the one I remember, that was one of the large GWAS or genome-wide association studies, was comparing different groupings of disorders, and they did find that psychiatric disorders are all genetically related to one another to some extent, but they're not necessarily related, let's say, to neurological disorders, even though they're both groups are disorders of brain function and brain structure, but a number of the neurological disorders were genetically related to one another. Most of the psychiatric ones share some degree of genetic overlap, but the two groups were not necessarily related to one another. So, but I don't know
That's
that
really fascinating.
That for autoimmune diseases. I would suspect that there are genetic relationships between OCD and certain autoimmune disorders, but I'm not as familiar with that literature.
Yeah, but I was just to add to that, I fully agree. Just to add that while we try to figure out what relates to what, genetically or otherwise, in a way, it doesn't matter. So while we wait for that, there are treatments for these conditions, or for most of them at least. So we need to make sure that people have access to those treatments. So that should be our priority while we wait for better science to fully understand what's going on.
Yeah, that's actually a phenomenal transition to kind of the clinical implications of this research. Maya asked a really interesting question, a better question than I could have formulated at 12:31, which is what would be the clinical implications for this research? Is the goal eventually to have nutritionists and physical therapists, sleep specialists, all kind of addressing a person with OCD?
Yeah, that'd be fantastic. It's what David was mentioning earlier today, that have a more holistic model where you not only do the Y-books, but that you're also, like your blood pressure is checked and they ask you how you slept last night or what you had for dinner last night. So that all is taken as a whole because the brain is also an organ. So I don't know why it should be like separated from the rest, and that we have also achieved a better collaboration between different health professionals.
Yeah, and as I said, there's a number of clinical implications for people with lived experience of OCD, and there's also major implications for family members, parents, and then clinicians. Is as we talked about at the beginning, the reminder of just how serious OCD is, and that one of the strongest signals that came out of this study, as well as the ones from Denmark and other countries, is the elevated rate of suicide. And certainly a good portion of that is due to co-occurring or comorbid depression, co-occurring anxiety disorders, co-occurring substance abuse. But even when you screen all those out or adjust for all those, there's still an elevated rate of suicide, just So OCD does appear to be an independent risk factor for suicidal ideation and even completed suicide, and as well as all these other medical conditions that we're talking about. So the message for people with OCD is to take.
Oh no, Sanjay, your mic's gone down again.
Oh, okay. Can you hear me now?
No, I can't. Yeah.
Okay, sorry. So yeah, the message for people with OCD is to take it seriously, get help, tell people about it, so that you can receive proper care for all these conditions as you go along. The message for parents and family members is to take it seriously in your loved ones and make sure that they get care for their OCD, as well as getting screened for all these other medical conditions and other psychiatric disorders. And the message for clinicians is to make sure that they're screening everyone who they see so that they can actually detect people who historically they've missed, right? Where they haven't detected it, and therefore they haven't treated it, and they haven't gotten those people into the healthcare system in a more effective way.
Yeah, something I'm definitely going to take away from talking to all you guys is like, OCD is really hard and it's really stressful. And Lorena, it's funny you mentioned contamination in the gym. That exact line of thought kept me out of the gym for years. So I think one thing I'm personally going to take away is like, it's really important to do the best you can as someone with OCD to take care of yourself, even like beyond just going to treatment. Outside of treatment, like trying the best to do, as David would say, like not rocket science interventions, just to try to live a little bit healthier, a little more actively. And you don't really have to wait for the science about all the genetic correlations to come out. Just kind of do the best you can each day, both inside and outside of treatment. And this study is just a really good wake-up call to be thinking about those sorts of things.
Yeah, definitely. Yeah, and for everyone suffering from OCD, I mean, you know better than anyone that OCD is not only the symptoms, is also, all the associated depression and beyond the mental disorders, the not feeling like cooking today or not wanting to go out, and problems in school or at work or being unemployed, or it is not only about your symptoms, but taking care of you as a whole as well. So I think that's probably a good takeaway message, that OCD goes beyond your contamination fears. And
I assume we didn't really talk too much about other psychiatric conditions, but I assume kind of the recommendation would extend. It's similar.
Yeah, I don't
in
think
like eating disorders and those sorts of things.
I don't think it's as specific to OCD. I think that the same recommendations apply to all mental disorders, and to everyone in general. It's just that by having OCD or having another mental disorder, you do have an increased risk of all these conditions we are discussing.
Mm-hmm. It dovetailed into a very nice note to end on. I didn't mean for it to come to such a nice kumbaya moment.
Sorry. No.
But I guess Lorena and David and Sanjay, we kind of maybe said some like initial ending stuff, but if you guys have any words of wisdom to folks with OCD, in the chat, there's been some level of anxiety discussing this topic, and that makes sense. I was a little anxious discussing this topic too. So if you guys have any parting words, I'll start with you, Lorena. Or actually, no, you just said some stuff. So
exactly. I think I will pass my turn to the others.
David, you've been quiet. I'm going to pick on you.
Yeah. It would be, let's abandon the old mind-body dualism. Let's think about people as a unity, and therefore treat OCD holistically. That will be it.
Short and sweet. I like it. Lorena, I'm going to go back to you now.
No.
You better have some mind-blowing insights that have not been said yet.
Now? Or I thought that you were going for Sanjay first. Yeah, no, I
No.
don't think I have any additional thoughts besides what we have already mentioned. But just like that, this is not. I think that information is power. That's what I want to say. Information is power, and it's better to know this than not to know this. And that we can take action because we know. So yeah.
Yeah, that was good. And Sanjay.
Yeah, again, I think to me, especially in the American healthcare system,
Your mic again.
We can't hear you. No.
Okay. Oh, there it goes. Now it's fixed. Okay. Yeah, I think the message in obviously the United States healthcare system is different than in all other developed countries, particularly in Northern Europe. So we have unfortunately more barriers to care. It's more difficult to navigate care, and it's more difficult to afford it because we don't have universal coverage in the way that most other developed nations do. So it's all the more reason to make a greater effort to really make sure that people do get care, and for parents and families who be very highly motivated to, let's say, take their child in for a respiratory problem or a liver problem or an autoimmune disease, but they're hesitant to take them in for treatment of their OCD, or they think somehow it's not as serious. This is a message that it is really serious and it is worth it. To try and get the care, and for people themselves with it to really seek help, to get treatment for themselves.
Yeah. This has been definitely an informative live stream. Uncomfortable at times, but informative, and I think ultimately helpful. I want to thank you guys all for being here. You guys have been super great panelists, and I also have a couple announcements that I want to make. First, we'd love to hear from you guys. So if you want to take a survey, there's a survey at IOCDF.org/livestream survey, where you can just tell us a little bit about what you want to see in the live stream programming and give us any feedback that you have. I also want to highlight that there's registration is open for the BDD conference. So if you want to see the BDD conference and have an opportunity to learn from professionals who treat BDD, you can learn more and register today at IOCDF.org/BDDCon. There's also 2 more live streams coming up. There's one tomorrow about supporting families, and there's one next Tuesday, the Faith and OCD Roundtable. I also want to express my condolences to HG in the chat. I read what you said. Thank you all for being here, and great stream.
Thank you.
Thank you.
See you soon.
Thanks. Thank you.
Bye.